Hey everyone, today we're going to break down one of the most important procedures in hepatology, something that can literally be a lifesaver for patients with severe portal hypertension. We're talking about the transjugular intrahepatic portosystemic shunt, or as you'll always hear it called, TIPS. Let's get right into it.
So what is a TIPS really? The easiest way to think about it is as a pressure relief valve. When the liver gets scarred from cirrhosis, it becomes really hard for blood to flow through. You get this massive backup of pressure in the portal vein, kind of like a seriously clogged pipe. What a TIPS does is create a new channel, a shunt, that lets blood bypass that clog. It's a pretty elegant piece of plumbing, really, designed to reroute blood and just instantly drop that dangerous pressure.
So here's how we'll tackle this. First, we'll look at the pressure problem itself. Then we'll dive into the TIPS solution. After that, a really crucial part, choosing the right patient. Then we'll cover life after TIPS, the big trade-offs. And finally, we'll talk about how we keep an eye on these shunts long-term.
Okay, so first up, the pressure problem. Why is this backup of pressure in the portal system so incredibly dangerous? Well, it forces the body to create its own detours for all that blood. And these detours, they are not built to last.
The body, in its attempt to fix things, forms these new vessels called portosystemic collaterals. The key phrase here is unsuccessful attempt. These new vessels are what we call varices. They're weak, they're fragile, and when they pop up in places like the esophagus or the stomach, they can rupture and cause a truly catastrophic bleed.
And you know, understanding the specific plumbing here is actually super important. Knowing which veins are feeding these varices and where they're trying to drain helps you understand why they form where they do. You can see here, for example, that the supply and drainage for esophageal varices are totally different from those in the stomach. This anatomy is why a TIPS, which decompresses the whole system right at the source, can be so effective.
All right, so we have this massive pressure problem. How do we actually fix it? This is where the magic of the TIPS procedure comes into play.
Honestly, this procedure is a marvel of interventional radiology. The whole thing starts in the neck, through the jugular vein. A catheter is guided all the way down into one of the hepatic veins inside the liver. From there, a needle is pushed right through the liver tissue to puncture the portal vein. That new pathway is then stretched open with a balloon, and finally a stent is deployed to prop open that new tunnel for blood flow. Now, the type of stent we use here is absolutely critical. The official ASLD guidance is crystal clear on this. The old bare metal stents, they had a bad habit of clotting off, but the modern PTFE-covered stents have just dramatically improved how long these shunts stay open. This is, without a doubt, the standard of care.
This number right here, this is the whole point of the procedure. The goal is to get the pressure gradient, the difference in pressure between the portal vein and the rest of the circulation, below 12 millimeters of mercury. Hitting this target is a game changer. It drops the risk of a variceal rebleed from about 35% all the way down to less than 5%. That is a huge, huge win.
Of course, just because we can do a TIPS doesn't mean we should on every patient. This is where clinical judgment really comes in. Patient selection is everything.
So who do we do it for? The big indications are for salvage situations, when a patient is bleeding and we can't stop it, or preemptively in really high-risk patients to prevent that first bleed. But, and this is a big but, there are hard stops. You're suddenly diverting a ton of blood back to the heart, which can totally overwhelm it. That's why congestive heart failure and severe pulmonary hypertension are absolute no-goes. Same goes for uncontrolled encephalopathy or an active infection.
So let's talk about that crisis situation, the salvage TIPS. The patient is bleeding out. You're rushing to intervene. Is there a point where even if you do the procedure perfectly, it's just too late? When does it become futile?
The data is pretty sobering on this. For patients who come in with a MELD score over 30 or a lactate level over 12, their mortality in the next 6 weeks is over 90%, even if you place a successful TIPS. In those cases, it's generally considered futile, unless, that is, it's being used as a very temporary bridge to an imminent liver transplant.
Okay, so for the patients who are good candidates, what happens next? What's life like after a TIPS? Well, relieving all that pressure comes at a cost, and it is probably one of the biggest trade-offs we deal with in all of hepatology.
See, by creating this shunt, you're bypassing the liver's main job, detoxification. All those toxins in the blood, like ammonia, now go straight to the brain. This causes a state of confusion called hepatic encephalopathy, or HE.
And look at this risk. It's not small. Somewhere between 30 and 50% of patients will develop new or worsening encephalopathy after a TIPS. That's a huge number to consider.
The good news is we can often predict who's at the highest risk. You need to be really careful with patients who are older, anyone who's already had episodes of HE, or those with really advanced liver or kidney disease. Identifying these folks beforehand is just crucial for having that honest conversation with them about the risks and benefits.
So, how do we try to lower this risk? Well, the modern approach is all about finesse. It's not about just throwing in a big, wide-open 10mm stent anymore. Instead, we start smaller, usually at 8mm. Then we carefully dilate it just enough to get that pressure gradient under 12. It's a much better balancing act, enough decompression to stop the bleed, but hopefully a lower risk of causing severe encephalopathy.
Finally, it's really important to remember that a TIPS isn't a set-it-and-forget-it procedure. That new pathway we created needs to be watched closely to make sure it stays open and working properly.
And the way we do that is with regular Doppler ultrasounds. This lets us measure how fast the blood is flowing through the stent. The standard protocol is to get an initial check within the first month, then again at 3 and 6 months, and after that, every 6 months for the long haul. This helps us catch any potential narrowing before it leads to another bleed.
All right, let's boil this all down to the key things you need to have in your back pocket for rounds tomorrow. Number 1, TIPS is a pressure relief valve. Easy. Number 2, the goal is a pressure gradient under 12 and you have to use a covered stent. 3, know those absolute contraindications cold, especially the cardiac ones. 4, the biggest trade-off, the constant debate, is preventing a bleed versus causing encephalopathy. And 5, these patients need lifelong surveillance with Doppler ultrasounds. Simple as that.
And that really leads us with the central question that we're always grappling with. As our technology gets better, as we get smarter about patient selection, we're still walking this incredibly fine line. How do we find that perfect, individualized balance for each patient, saving them from a fatal hemorrhage without pushing them into a life of debilitating confusion? That right there is the art and the ongoing challenge of what we do. Thanks for tuning in.